for cancer management. اتفضل دكتور أحمد. بعد إذن حضراتكم هنخلي الدسكشن بعد نهاية السيشن.
السلام عليكم. Vertebroplasty, cementoplasty, and embolization for cancer management. The role of intervention radiologist in the palliation of pain has evolved during recent years, including expansion of thermal ablation for treatment of painful osteolytic and osteoplastic metastatic lesions. Percutaneous image-guided thermal ablation with or without subsequent cementoplasty had emerged as a safe and effective treatment for painful osseous metastasis. Combination techniques may improve pain relief after therapy through devascularization, and also in cases of visceral pain, percutaneous neurolysis has a specific, for the specific sympathetic nerve plexus, can be chemical or by thermal radiofrequency or cryoablation. So how to kill the cancer? We can kill the cancer by chemical ablation, by alcohol, and also by radiofrequency, by microwave ablation, by ultrasound guided, like in HIFU techniques, by laser ablation, by cryoablation, by induction of ischemia, and also by injection of a chemotherapy directly inside the tumor. How to kill the cancer pain? By celiac or splanchnic neurolysis, by hypogastric block, by ganglion impar block, by satellite ganglion block, stellate ganglion block, by bone ablation, by vertebroplasty, lumbar sympathetic block, and also by treatment of the spinal pain associated. The techniques, in this lecture we can discuss some techniques. Percutaneous vertebroplasty, percutaneous vertebroplasty plus percutaneous fixation, bone metastasis cementoplasty, bone metastasis ablation, and also embolization for metastatic osseous lesions. In this technique, we performed vertebroplasty and kyphoplasty at multiple levels. So we can see the needle here inside the fifth dorsal vertebral body, and by injection of the cement inside this. This is the 3D reformatting CT, and also we can inject the cement inside osteolytic lesions in the pedicle or in the vertebral body percutaneously under fluoroscopic techniques. We can see the cement concentration here inside the vertebral buds. Inside this technique, we can insert the pedicle, the needle, the screw inside the pedicle, transpedicular approach, and also we can avoid attachment of the dura. We can avoid injury of the dura in this place, and also we can perform. We can make multiple rotations to ensure our position inside the vertebral body. You can see the CT reformatting image. After this, we can see the concentration of the cement inside, and you can see this is a small paravertebral venous leak. It's very safe, no doubt of this. This is the 3D rotational in another image. This is a solitary spinal metastasis. We can see that in the solitary spinal metastasis that the vertebroplasty can be curative, so it can kill the cancer as well by induction of heat and denaturation of the cancer cells in this case. Also, the vertebroplasty can make regression of the tumor size, like in this patient where the tumor size was regressed markedly. And in this technique, we can explain the vertebroplasty by 1, 2, 3, 4, 5, 6. 6 lives at the same level, at the same setting. You can see this is a multiple myeloma patients. The vertebral buds are distracted, all lumbar buds are distracted, and the last dorsal vertebral body is also distracted. We performed vertebroplasty in these levels. We injected the cement by stage 1, and also stage 2 injected the cement inside the last three lesions. The second technique is the percutaneous fixation with vertebroplasty. In this technique, we don't open the skin, we don't make suture. It is a sutureless technique. And in this technique, we injected the cement also plus the screw by cannulated screws. And this is explanation with my neurosurgery colleague. When we perform this is a vertebral plana in this vertebrae, and we inserted the needle here and the needle here. You can see the last image here. This is our explanation. The cement was concentrated here, and the cement was concentrated here, and also the final image, the cement was here in both sides, and after removal of these machines, we can make our percutaneous fixation. This is another case where we performed fixation here. We performed fixation with vertebroplasty to the intermediate vertebral body. It is not true vertebral planus. So we injected cement here and here and here at the same time. And this is the image before final fixation. And you can see this rotational fluoroscopic dynamic image in real time, where the cement was concentrated here and the cement also was concentrated here, and these are the roots, and the screws are inserted inside the pedicles without skin opening. The third technique was bone metastasis cementoplasty. In this technique, we performed what is called reinforced cementoplasty, which is a percutaneous internal fixation using dedicated spindles combined with cementoplasty. This is one of our cases when we perform it. This is a case from literature, and this is one of our cases, you can see, when the patient who suffered from an osteolytic metastatic lesion in the shaft of the right femur. We decided to perform the injection of the semen and also the insertion of the screws. We can see the steps of the patient. In this patient, the screw 1, the screw 2, and all these 2 screws, and also the third cannulated screw when we injected the semen, and this is the final image. Fortunately, after that, PET-CT was free in this region, and the patient was felt good. The fourth technique was bone metastatic ablation. It's one of our cases which we performed bipolar radiofrequency for this metastatic lesion from HCC. We performed bipolar radiofrequency using the technique of bipolar radiofrequency to kill the nerve endings at the tumor. We don't direct this lesion to kill the tumor itself, but we killed the nerve ending. We ablated the nerve ending to make patient free. And this is another case with metastatic HCC in the ischem, when we performed microwave ablation to directly kill the tumor and distract the tumor cells and also distract the nerve ending. The last technique we performed is embolization to deprive the tumor from the blood supply. This is a patient with large metastatic lesion from breast cancer, when she suffered from severe pain, not responding to opioids. We performed complete embolization with measures to protect the skin, and after that the patient was free. This is another case with metastatic breast carcinoma as well. We performed also embolization for the ischial branches because the tumor was in the sacrum and the ischium. And this is another case. The patient was metastatic rib lesions, in this case from HCC. We performed intercostal approach and the selective embolization for the hypervascular lesions inside. You can see the blush before and you can see the blush after. This is another case with metastatic also HCC in the shoulder, and the patient was performing prosthetic replacement because there was vanishing bone in this area, but the tumor was recurred again, and this is a large mass in the shoulder. We performed large-scale embolization for the patient. In conclusion, the role of palliative procedure is evolving as a part of comprehensive interventional oncology service. The interventional radiologist has unique skills and experience in the diagnostic image interpretation and a depth of knowledge in minimally invasive imaging-guided procedures. Thermal ablation of masses, neurolysis, and the combination of multimodality image-guided techniques can be applied in a variety of situations for effective pain relief. Thank you.